ACCEL continues with a discussion Raymond Gibbons had with Dr. Silvana M, Associate Professor of Medicine at the Baylor College in Houston, Texas, on are the Bethesda guidelines still relevant for the pediatric athlete with heart disease in 2013.
Welcome to ACCEL, Silvana.
Thank you very much. My pleasure.
Now, I think our listeners are generally familiar with the fact that Bethesda guidelines were published, and you and I discussed beforehand the fact that that publication actually took place in 2005. So that was 8 years ago. Given that passage of time, are the guidelines still relevant in general terms?
I do believe that, yes, they are, and presently they remain the guidelines by which we usually refer to in terms of prescribing exercise restriction to or not to our patients. However, having said that, I think that there are several new developments and new science that has perhaps challenged some of the concepts and some of the guidelines pertaining to some specific situations.
So in the same way that we update guidelines on stable ischemic heart disease or unstable angina, the Bethesda guidelines probably merit at this point some updating for specific issues that have emerged in the last 8 years.
Absolutely. I do believe so. And I think especially as to what pertains to the pediatric population.
Well, let's help our listeners understand what they need to know that has occurred in the last 8 years that are relevant to pediatric athletes. So let's start out with the issue of anticoagulation.
Perfect. One of the challenges that we have is how to tell a 3-year-old, for example, that who's on Coumadin and who maintains an INR of 2.5 or to 3 to really not perform any contact activities. This is nearly impossible. As we counsel these patients, we can't possibly say if you are on anticoagulants, you can't exercise. In addition to that, as you know, participating in some type of recreational activities or even, engage in sports at this age is important. And I think that we probably need to revise, especially with regards to the age that we are referring to. In general, yes, Coumadin should not participate in any contact sports. However, perhaps we can be a little more specific to the younger patient who is on anticoagulation.
And by younger, perhaps less than 10, less than 5? Just help our listeners.
I would say probably at least less than 10, which again, those can be age-appropriate activities, such as soccer, which is very, very common. And yes, can be contact, but certainly in lesser terms than you would anticipate after 10 years of age.
And do you think that should be an important issue, for example, in the choice of valve in the pediatric population who are potentially going to be interested in athletics in the future?
Absolutely. As you know, there are several papers in the literature that address, is the Ross procedure the best way to go, and should we put a different valve? I think that probably it's more challenging those patients that have both mitral and aortic valve disease. And I think that that's a challenge, and especially when we talk about mitral valve replacement, because then we really don't have any other options except really in kids to keep them on anticoagulation.
Okay, I think that's helpful for our listeners. Let's move on to channelopathy. It's an area of great scientific interest. A lot has been done in the last 8 years. How should our listeners factor that into the issue of evaluating pediatric patients for athletics?
Absolutely. I think that there has been some beautiful work that has been published recently citing what is the outcome of patients who have genotypic and phenotypic expression of long QT syndrome, for example, who choose to exercise, not only exercise, but actually be in competitive sports. And truthfully, it appears that the occurrence of sudden adverse events is extremely low. And in addition to that, I think that one of the factors that we have to consider is that nowadays our families are so well educated, and the decision of play or not to play rests not only on the cardiologist, but largely on a combination of factors in terms of the family and certainly the physician. And that's what we face presently. So I think that going back to channelopathies, it is something that probably we will need to revise as to our determination of you should not play, you should not compete if you are positive for genotype and phenotype.
And certainly a moving target from the standpoint of the science.
Absolutely, and very, very exciting, I think.
Let's go on to another issue, that of aortic valve disease and aortic root dilatation, something we're, I think, more aware of now than we were 8 years ago. How do you approach that issue in a pediatric patient?
I believe that probably whenever we come to revise the guidelines, we will have to probably explore a little bit more aortopathies. I think mostly the Bethesda guidelines refer to aortic stenosis and aortic insufficiency, but I believe that we should be a little more specific with regards to that. I think that the patients that have a genetic condition, a genetic mutation, I think that those probably are easier to determine, and you know by several studies what the outcome is in those kinds of situations. However, having said that, those patients that do not have a genetic mutation, for example, situation of bicuspid aortic valve or bicommissure aortic valve, which some patients do develop aortic root dilation. This is an area where we need to be perhaps a little more specific. And again, it's not going to be a specific value, but as you know, in the pediatric population, we'll be very much driven by Z-scores.
So I think adult cardiologists may not be familiar with that concept. So help them understand, how does a Z-score help you decide?
So the Z-score is essentially a mathematical, obviously, equation that takes into account the measurement of the root to the body surface area. And we do know that above a body surface area of 2, the Z-score value really becomes not very predictable, if you will, of true abnormality. And essentially it gives you the normal range would be between -2 and +2, which essentially gives you the 2nd to 98th percentile of what the normal population curve should be.
So it's a method of adjusting for body surface area.
Correct.
Okay, well, finally, obviously our listeners have heard a lot about the controversy of whether we should be doing ECGs in all kids. And there are strong opinions on both sides of that issue. Do you want to express your own personal opinion on this issue for our listeners?
Yes, I do, actually, if I may. I truly believe that we urgently need better criteria. Our population nowadays in the U.S., it is clearly multiracial and multi-ethnic. And we cannot still base our ECG interpretation in wonderful work, but work that has been done on a specific white population over 40 years ago. And in addition to that, we have a very different BMI as well in our population when you look at pediatric patients. So I believe that perhaps the first thing that we need to do is really gather sound data as to what are we seeing in this population that is quite different from what we had the data that was based over 40 years ago.
So a simple message: Americans are more diverse and heavier than they were in the past, and our ECG criteria need to reflect that.
That is correct, sir.
Well, thank you very much, Silvana. I think our listeners have heard that the Bethesda guidelines are still worth reading, but that areas of potential change that they should be aware of include the issue of anticoagulation, the issue of channelopathies, aortic dilatation, particularly in association with aortic valve disease, and they should stay tuned to the controversy about ECGs in pediatric patients. Thank you very much.
Absolutely, my pleasure. Thank you.